Welcome everybody to my lab. So essentially in this lab I'm going to speak about ASD. Now ASD is also known as a left to right shunt. Okay, it's under the groups of a left to right shunt. So essentially what happens, okay, what are the causes? There's lots of genetic and environmental causes as well as idiopathic causes which is unknown. The pathophysiology includes of that of an anatomical defect in which there is an atrial septal opening, and over here you can see that is the atrium. It is open, okay, and blood can flow from the left side of the heart to the right side of the heart. So essentially, you have the septal opening between the right atrium and the left ventricle. There are different types. You get at the middle of the atrial septum near the AV valves, the aortic, the atrioventricular valves, and or you could get it near the junction of the superior vena cava and the right atrium. Okay, but the hemodynamic changes includes a left to right shunt because of the high pressure in the left atrium. Right, the increase you get increase in pulmonary blood flow because what happens is that the the if blood goes from the left atrium to the right atrium and then it goes to the right ventricle and it pushes blood towards the pulmonary circulation, there's increase in the pulmonary blood flow. Systemic changes include a reduced cardiac output because of the shunting of oxygenated blood back to the pulmonary circulation. As you know, that oxygenated blood comes from the lungs to the left atrium, but now that oxygenated blood goes now to the right atrium, there's less blood going to the left ventricle and less oxygenated blood goes to the via the aorta. So less volume of blood means a less cardiac output. So, what are the things on history that is quite important to kind of recognize for babies with ASD? So, essentially, some babies are quite asymptomatic because it's an acyanotic disease. The blood is oxygenated. It's just that there's a little less. There's no mixing of oxygenated with deoxygenated blood. Um, Okay, there is, but I mean, like the blood going towards the systemic circulation is quite well oxygenated. However, because of this increase in the pulmonary flow, increase in the blood into the pulmonary circulation, you can get the pulmonary hypertension, and that could give you a pulmonary edema first, which could lead to recurrent RTIs, dyspnea on exertion. Okay, exercise intolerance, fatigue, growth and development, right? Failure to thrive, fatigue, right? And then on CBS, you have palpitations in older children as well. Cyanosis can also occur. Okay, now, okay, this is should also family history, and then maternal or perinatal conditions, and then developmental history, failure to thrive. So on examination, palpitations in older children. So on examination, essentially, the general exam, you can get edema in very severe cases. Okay, so patients could present with edema in severe cases. You get normal pulses, right? So you get normal pulses in ASD. On auscultation, you get the systolic ejection murmur. Um, and the reason why I'm heard at the lateral cell border, left flow cell border, because of the increase in flow across the pulmonary valve, right? So increase in flow across the pulmonary valve causes systolic ejection murmur. You can also get a fixed split S2. because of a delayed closure of the pulmonary valve, right? Because essentially there is so much blood pushing back as it closes during a split S2. So during S2, what happens is that so let me just think quickly. During S1, the pulmonary valves open, and then during S2 the pulmonary valves needs to close. But because of the delayed closure, because so much pressure is built up in the right ventricle, that the delayed closure causes a fixed split S2 sound. And in some cases you can get a diastolic murmur, which is low pitched. So this patient also presents with a quite low pitch diastolic murmur, and the reason why is because of increase in flow across the tricuspid valve, right? So during diastole, when because now there's so much blood going during diastole, when you have uh, when the heart kind of relax as well as atrial contraction, that increase in flow through the tricuspid valve kind of gives that sound in some people, in some patients, of a diastolic murmur, a very low pitched diastolic murmur based at the left lower sternal border. You can also get a right ventricular heave because of right ventricular enlargement. Okay, so a right ventricular heave at the lower left sternal border because of RVE enlargement due to the volume overload. So because of that volume overload, you get that heave. Okay, you get that heave of the right ventricle, and then you can patients also get a hyperdynamic precordium. Okay, and then if there's right heart failure in two patients can also present with a hepatomegaly. Okay, now in terms of investigations include an echo, so an echo and ECG to detect right atrial dilation, right ventricular hypertrophy when incomplete right bundle branch block, chest X-ray for cardiomegaly and increased pulmonary vascular markings or left pulmonary edema, cardiac catheterization for hemodynamic assessment, and then plus minus MRI or even a CT. Management include conservative management if it's less than 5 uh, millimeters. Here we have, in terms of medical management, we have diuretics, ACE inhibitors, as well as beta blockers, all for that right heart failure. So over here we have for the right heart failure or cardiac synthetic material. In terms of complications, so complications tension, right heart failure because of increase in the workload. Let me just see, yeah, good, and yeah, okay. You can also get atrial arrhythmias, and then you also get the Eisenmenger syndrome. Now, the Eisenmenger syndrome is essentially when there's a reversal of the shunt due to the pulmonary hypertension. Okay, Eisenmenger's syndrome. So, because of the pulmonary hypertension, so much pressure can build up in the pulmonary circulation. It can push back into that pressure can push back into the right ventricle, into the right atrium, and back through the atrial septal defect, causing then a right to left shunt. Patients also have a paradoxical embolism, failure to thrive, exercise intolerance, as well as an endocarditis can ensue as well. Okay, and that is basically it, everybody. And then that's the image of cardiomegaly as a result of, well, in this case it shows left, but in it will have a right atrial and right ventricular hypertrophy and dilatation, and you can see those increase in the pulmonary vascular markings indicating pulmonary congestion. That's it, everybody, for atrial septal defects.